I'm an assistant attending at HSS and on the arthroplasty service. And by way of disclosure, I do consult with the Pew, which won't be discussing much in this talk. But as another disclosure, I am a trauma-trained surgeon, so that's both arthroplasty and trauma, and I do a fair amount of fixing of these as well as revising them. So I want to take a little bit of time today to go over things that I've learned in my first couple of years of practice here, treating a lot of these challenging cases. And I think whenever you talk about periprosthetic fractures, going back to the classification system is important. So we're going to start there and then go over the epidemiology and the etiology of these fractures, which is a moving target as hips are becoming more and more modern. Main modes of failure, and then we'll talk about a specific case example. So the Vancouver classification came about in the 90s out of Vancouver, and was really based on a cemented stem model. So although it's not a perfect classification for today's world, it does give us a lot of help because it is predictive of how these fractures should be treated according to classification. So you have the A's, which is both the greater or the lesser involved, and that typically is a stable stem with a greater choke fracture or lesser choke fracture. Now the B's are what we'll spend the majority of the time talking about today. A B1 is a fracture with a stable, around a stem, but with a stable femoral component. B2 is where the femoral component is unstable, and then a B3 is with fracture around the stem with an unstable component, but also a big deficiency in bone around it. And then a C is distal to the stem, and there's a little bit of controversy because there is a fracture that occurs at the tip of the stem, and a lot of times people don't know how to classify that. Personally, I think that is a B because it's related to the stem. For a C fracture, it has to be something in my mind that would have happened if the hip replacement wasn't there at all. So the epidemiology, the American Joint Registry has come about in the last few years, and it's come up with some interesting articles. And this one out of Ortho Carolina, they looked at the American Joint Registry and found that over 12% of early revisions after total hips are related to periprosthetic fracture. So a good chunk of early failures, 17% of early failures, are going to be because of a fall or a fracture. And 6.2% of all revision arthroplasties accounted for by fractures. I would argue that that's an underestimation of where we are at today. We know aseptic loosening, instability, and infection are really common causes of revision, and fractures usually put slower down on that list. But I think as more and more uncemented stems are being put in and older patients, the rate of this is going to go up and up. And I don't think that we fully account for the problem because in our registry data, we're not incorporating reoperation for fixation. We're just incorporating revision reoperation. So I think it's a growing problem. It's something that we should be paying attention to more and more. This is out of the Mayo database, and this is a 20-year longitudinal study. And what I want to point out with this slide here is that if in their study, in their data, if you had an uncemented stem over a 20-year period, you have nearly an 8% risk of having a fracture at some point along that way. And the risk goes way down with cemented stems. And this is borne out in not just the Mayo data, but in the UK data, the Nordic data, the New Zealand data. So it's very clear that cementing a stem protects you against intraoperative and perioperative femur fractures around a hip replacement. Despite this data, the ACUS poll, so poll of all American surgeons, found that 93% of surgeons go uncemented over 75% of the time. So not that many surgeons are incorporating cement into their routine practice. And I would argue that's probably the biggest thing that we could start doing to lower the rate of periprosthetic fracture. And one thing I'll point out on this slide, if you look at the over 90-year-old group in the US, 65% of patients over 90 are getting uncemented stems, which is a little crazy in my opinion. And I hope to see the cement usage go up in the coming years. So we talked about the main reason I think why patients fracture is cementless stems. That's an obvious risk factor, particularly in older patients, female patients. And then of course, femoral morphology. So we all use the Dora classification, stovepipe femurs, poor bone quality, and that's a risk for fracture. But newer things that we're talking about more approach. So Dr. Ranawat can probably go off a little bit about the approach here, but we know certainly in the early learning curve period of an anterior approach, a risk of fracture is higher. Tapered stems, certain types of stems are at higher risk. Clearly missing an intraoperative fracture puts you at risk for a perioperative subsidence, and we'll talk about that. And then undersizing the femoral component. So a little counterintuitive, but I'll show you what I mean. Undersizing the femoral component, I think, is a big risk that we're not understanding fully yet. So I had a fellow last year that looked up our early periprosthetic fractures at HSS. So these were the ones that were occurring in the first 3 months after an index primary routine total hip. And he matched them to 2 controls or patients that didn't fracture early on. We matched them according to make and model of the implant, surgical approach, age, sex, and BMI. So we were really trying to hone in on the sizing and alignment of the component and how that affected risk. And he made a lot of measurements, and what he came up with was the medial congruity is a very important thing to look at in your intraoperative or postoperative film. So the more medial incongruity you have, the higher risk you have for fracture. And we think this is because that's going to increase your risk of subsidence, and subsidence, a sudden subsidence, can lead to that catastrophic periprosthetic fracture. So you can see the example here, undersizing slightly, not ridiculously, but undersizing, and then an early subsidence, and then the late subsidence leading to this fracture. The medial incongruity is similar to a valgus alignment too, that increases the medial incongruity and increases your risk of early fracture. The other thing we've been looking at is what happens if you do have an early fracture. What is the result? And the result is really sobering. If you have to take somebody back in the first 6 weeks for a fracture, your rate of periprosthetic joint infection is incredibly high. So over 10% at our institution. And this is in line with other studies that have shown that if you take people back to the OR within the first 6 weeks for any aseptic reason, your subsequent rate of PJI is really high. So I think this is a group that we can target to lower our risk of infection going forward. When we look at all comers at HSS, so all periprosthetic fractures over a 10-year period, again, the results are pretty sobering. So we found that the reoperation within 2 years of any periprosthetic femur fracture was 19%. So nearly 1 in 5 patients is going to have to go back to the OR if you take them for surgical fixation or revision of a periprosthetic femur fracture. And I think the biggest thing I've learned about that group in the past 2 years has been they fail for different reasons, and they fail for different reasons according to the fracture pattern they have. So greater troch fractures have a very high failure rate, and they fail for both non-union and infection. So I've become a little bit more of a nihilist when it comes to fixation of greater troch fractures, because I've just looked at so many x-rays in doing these studies of seeing how frequently the troch will displace, and then how frequently they will get infected if you try to plate them. B1s, fractures with a stable stem that you fix, tend to go on to non-union, and you can see the x-ray here. I'll talk a little bit about this in the next few slides, how non-union is such a big factor that the varus deforming forces are overwhelming. So getting these to heal is a real challenge. B2s, particularly the early ones, go on to periprosthetic joint infection. And then Cs, I really think of them as a different animal. So those are an elderly group with a lot of medical complications. While you can get them to heal, and they may not have the most orthopedic problems, they do have a lot of medical comorbidities and complications in the hospital to keep note of. So like I said, the greater troch data is very sobering. So this is out of Mayo. This hasn't been published yet, but this is 170 or plus trochanteric fractures, very high non-union rate, very high limp rate. So that's where I'm not sure exactly who coined this term, but once the greater troch has tasted its freedom, it's very hard for it to return. And I think that is certainly true. And hopefully over the course of my career, we'll come up with better ways of getting that to stay put. But so far, it's been a real challenge. We looked at our series here, and 44 cases or so, very high revision rate at 20%, very high non-union rate of 31%. We thought that this Arcos bolt system where we have a plate attached to the revision stem was going to be really a game changer, and that's not borne out that way. A lot of failures with that implant as well. So I'd be very cautious with any sort of fixation on greater trochs, and I think more to come. Like I said, B1s are the stable stem where you try to fix them, very high rate of non-union. I think that's because of the varus deforming forces. So I'm going to go over a case of this and lessons that I've learned from my own failures. And what I do now is I span the entire femur. I double plate them when I can. I use a stiffer plate whenever possible. I try to lag things when I can. And if it's a really, really tough pattern, I'll consider even revising the stem. The ones that occur at the tip of the stem are really the bad actors. So these are the ones that some people would call that a C. I call that a B1 because it's so much involved with the stem. Really challenging mechanics and a high non-union rate. Overcoming that varus is incredibly important. You can see even dual plating at times is not the solution. B2s, very high infection rate. So I think using any strategy you can to mitigate that risk is going to be really key for taking patients back for B2s, particularly the B2s that occur in the early stages. Now, a couple things to consider for B2s. We're looking at this with the various studies at HSS now is the two different approaches to them. One, reconstituting the tube and then potting your stem, or two, preparing the stem and then cabling the fragments around the stem. I use both approaches. I think it really depends on the fracture pattern. So far, we haven't really shown that one approach is better. You have both options available. And then a quick note on Vancouver C fractures. Although this didn't bear out statistically, I did find when looking at a lot of these C fractures or fractures distal to the stem at Mayo that the short segment fixation does very poorly. So whenever you have this fracture, I think spanning the entire femur is incredibly important. So the one thing that I've tried to do now is plate all the way up to the lesser trochanter, and I've found that that's been helpful to get these to heal. So no short segment fixation, and try to get all the way to the lesser. So in summary, what I've learned is that the A fractures, the greater troch fractures, are very difficult fractures. They tend to fail in non-union or infection. The B1s tend to fail by non-union. They require a lot of metal to overcome those deforming forces. The B2s will fail from a periprosthetic joint infection. So I think using any strategy you can to mitigate that risk is important. And Vancouver Cs, really watch out for the medical complications that arise with these patients. I think I'm a little bit short on time, so I'm going to fly through these slides. This is a B1. I'll just show you briefly how I fix these now that I've had several failures. I try to position them laterally so I can get good x-rays. I use a subvastus approach. I use 2 screws whenever possible to lag the fracture and hold it in position. And then I use a recon plate anteriorly or posteriorly, depending on positioning of the fracture, and a large locking plate laterally. Try to span the entire femur and contour the plate into valgus, and that can help to overcome the deforming forces of varus that you experience throughout the femur. So you can see this patient did well. So in summary, overcome it with metal. I think using cables when you fix these should be done very reluctantly. Whenever you can get screws around a stem, you should. I make a big incision and don't go minimally invasive. I try not to miss a loose stem because that can be really catastrophic, and treat and prevent infections whenever possible. Thank you guys so much for your attention.